Um, Good morning, and thank you for attending our Grand Rounds lecture. I am pleased to introduce to you Dr. Melinda Davis. Dr. Melinda Davis is here today to talk to us about peripartum cardiomyopathy. She's an associate professor of medicine in the Division of Cardiovascular Medicine at University of Michigan. She's director of the University of Michigan Cardio-Obstetrics program, serves on the Michigan Maternal Mortality Review Committee of the Department of Health and Human Services, the American College of Cardiology Cardiovascular Disease in Women Committee, and the ACC Cardio-Obstetrics Work Group. Her clinical and research interests focus on pregnancy-related cardiovascular disease, including preeclampsia, heart failure, and peripartum cardiomyopathy. Dr. Davis is dedicated to medical education and serves as the Fellowship Program Director at the University of Michigan. We are very grateful for Dr. Davis's expertise on this topic and look forward to learning from her. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function of Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds Conference series. To claim credit for today's session, text the code shown at the beginning and the end of this presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com. And now I'll turn it over to Dr. Davis.
Well, thank you very much. I really appreciate the introduction, and I am most appreciative of the invitation. It's very nice to be here with all of you today. So today I get to talk about one of my absolute passions in life and favorite topics, which is peripartum cardiomyopathy. And I thought I would start by just telling you a little bit about sort of the context about me and where I work. The field of cardio-obstetrics has been growing and developing and is now named cardio-obstetrics, whereas before it was a little bit less defined. But what we are doing here at University of Michigan is really focusing on this multidisciplinary care of our patients. And we take care of all different types of patients related to pregnancy. So this is we've recently developed a joint program. So I have a clinic over in the women's hospital. So patients can come and see both me and my maternal fetal medicine colleague, Dr. Langen. And this is a picture pre-COVID. We talk about all of our high-risk patients every month who are pregnant, and we create management plans together. So this is sort of the context in which we work. And then one of my absolute passion, as I mentioned, is peripartum cardiomyopathy. And so this is an example of why I think this is such an interesting diagnosis. So imagine a 32-year-old woman. She has just delivered her second baby just over a week ago, and she's having worsening shortness of breath and edema and chest pressure, palpitations. And she thought all of this would get better after she delivered, but in fact, all of it has gotten worse. And she even noticed a lot of this during pregnancy, but people were, but people said, well, that's typical that, you're towards the end of your pregnancy. Of course, you'll have a lot of those symptoms. And she just kept thinking, well, but it's worse than my last pregnancy. But nevertheless, then she delivered. And then she comes in a week after delivery. She has a newborn at home. She comes in and is diagnosed with peripartum cardiomyopathy. Her ejection fraction is 20%. And if you can imagine sort of the shock of being a young person with two little kids, a newborn, and a new diagnosis of heart failure, it's quite overwhelming. And that's part of the reason why I am so dedicated to this patient population. So my objectives for this talk are to review peripartum cardiomyopathy, the current definition, some of the risk factors for this, and then management of heart failure during pregnancy and with breastfeeding is a little bit different than your typical HFrEF management. And then there's some areas that have some gray to it, bromocriptine, anticoagulation, and when would be appropriate for a defibrillator. And then lastly, patients really do often want to have another pregnancy, and how should we counsel them? And something that we often don't think about as cardiologists is contraception. So this is how I'm going to tackle today's talk. We'll talk a little bit about the context of maternal mortality, definition and risk factors. I'll mention the pathophysiology, and then we'll get into the management, outcomes, and subsequent pregnancy. So a few years ago, this is what really came to the headlines is the maternal mortality rate in the United States is rising and is high, and quite inappropriately so. Black women have 3 to 4 times higher maternal mortality, morbidity. And why is that, and what is going on? So there were a lot of papers in New York Times, NPR, Politico that have raised attention to this issue. And when we look at the United States compared to other countries, the maternal mortality rate is really quite outrageously higher. And so why is that? Well, when they've done reviews, this is from Joan Briller and colleagues from Illinois, they looked at their maternal mortality review committee and found that cardiomyopathy is the major cause of death. And when they reviewed the causes, they found that a substantial proportion are preventable. So this is a really important topic for us to address. Peripartum cardiomyopathy has also been stated to be on the rise. And whether this is because we are more aware of the diagnosis and diagnosing it more often, or whether risk factors are increasing in the population. Women are older, there's more hypertension, more assisted pregnancies with multifetal gestation. There are several possible explanations, but this is definitely something that we see. So peripartum cardiomyopathy was formerly defined quite strictly that it was in the last month of pregnancy or in 5 months postpartum, but it's been broadened to the new onset heart failure that's idiopathic, that's happening at the end of pregnancy or in the months following delivery. These patients don't always fall exactly in that specific timeline window. And some important things is that it is a diagnosis of exclusion. It is a systolic dysfunction with the EF typically less than 45%. And then patients can have such a variable outcome. Some will recover quickly, some recover over a long period of time, some have terribly progressive symptoms and very poor outcomes or mortality. And the time that patients present the most is in that first month postpartum. And so here the green is the typical timeline, the former diagnosis of in the last month of pregnancy up to 5 months postpartum. But patients can present earlier, but the most common time that we see this is right after delivery. And one thing that we're seeing more and more often in our postpartum patients is clinical heart failure, but with normal systolic function. So I would not call that peripartum cardiomyopathy. I do think we're seeing some diastolic dysfunction that is presenting after delivery, more common in the setting of hypertension or preeclampsia. And I think the long-term outcomes for these patients has yet to be defined, but we do want to identify women with cardiovascular risk factors and help manage those long-term, but I wouldn't call that specifically peripartum cardiomyopathy. Other things to think about as your differential diagnosis for new onset heart failure in the setting of pregnancy would be preeclampsia, hypertrophic cardiomyopathy, or Takotsubo, or myocarditis, or valvular disease, congenital heart disease, ischemia, which can happen even in young women. Some women might have a lot of serious illness like sepsis or a pulmonary embolism, or a history of cancer that has been treated, and now a cardiomyopathy. So those are things to think about that would be alternate diagnoses. This is a table that talks about different Things that you would consider on your differential diagnosis. This is from the Jack paper from 2020. So there's lots of detail here, but this basically says the same thing with some more detail if you need that for future reference. Women often are misdiagnosed. And by the time they come to cardiology, they usually do have a diagnosis. So we're not usually on that front end. But the reason why I think it's really important to have this in mind is because by the time women come to see the cardiologist, they've often had a very difficult road of being misdiagnosed, of feeling like they weren't heard, feeling like they were dismissed, feeling like the medical system wasn't there to help them. And they feel like they may have had a delay in diagnosis. So all of these things are really common and important. Women can be told that they're having new mom anxiety, all kinds of things to explain their symptoms when in fact, it's heart failure. In cardiology, we are very comfortable using BNP. And sometimes the question comes to me, what about during pregnancy? Is BNP useful? And it's very useful. In fact, I find it one of the most useful tests because of the overlap in symptoms of a normal pregnancy and those of heart failure. BNP can be very useful. I tend to use pretty similar cutoffs in my mind to a non-pregnant population, but this study looked specifically at pregnant women, and they found that the optimal BNP cutoff would be 111. But I think obviously you would take the BNP level in the context of the patient and their symptoms, but just know that a BNP is a very useful test when you're trying to differentiate some symptoms that could be pregnancy or it could be cardiac. And then the other important thing is that an echo is always indicated when you are worried about the possibility of peripartum cardiomyopathy. Women who are at increased risk, African-American women have a higher incidence, more severe presentation, more delays in diagnosis, and tend to have worse outcomes. Preeclampsia and hypertension are also significant risk factors. The extremes of age, very young or very old, multi-gestations, so twin pregnancies, women that have had more pregnancies also tend to be older. And then there's a variety of other risk factors that have been identified. And I've done some work also looking at which of these risk factors can we put together into, say, an electronic medical record that we could have some additional risk prediction for patients. So I think that would be an interesting and helpful thing to help raise awareness of this diagnosis. The preeclampsia story is really interesting with peripartum cardiomyopathy. So this is from Zoltarani and his group. He did a meta-analysis of all the studies of peripartum cardiomyopathy. And if you look at the left, the green is all deliveries, and the tiny red sliver are patients who have preeclampsia. But then what about all the patients with peripartum cardiomyopathy? That huge red chunk is women who had preeclampsia and peripartum cardiomyopathy. So there's a big overlap there. And so how is that going to help us? So we think about all the different types of hypotheses that have been proposed for the diagnosis. Could it be some type of viral myocarditis or an autoimmune process or selenium deficiency or just the hemodynamic stress of pregnancy? That's a pretty common hypothesis. But let's take a closer look at that. So when we think about where patients usually present, it's clearly in that first month postpartum, as I showed you in a prior slide. And then let's look at the hemodynamic changes of pregnancy. So on the right-hand side, these along the bottom are the weeks of pregnancy. So sort of first, second, and third trimester, loosely defined here. And then on the y-axis is the percentage change from pre-pregnancy. And first trimester, a lot of hemodynamic changes are occurring, but here in the second trimester, those have really peaked. your cardiac output has gone up almost 50% from your baseline. Your stroke volume is up, your heart rate is up, and all of those changes have really peaked by the second trimester. So if peripartum cardiomyopathy were caused by hemodynamic stress, you would think that patients would be mostly presenting there in the second trimester, but they don't. And this is data from ROPAC, which is the International Registry of Pregnancy and Heart Disease. And they found that dilated cardiomyopathy patients with pre-existing known cardiac disease did in fact become symptomatic primarily in the second trimester, which correlates with those hemodynamic changes. Whereas patients with new onset, idiopathic, diagnosis of exclusion peripartum cardiomyopathy presented much more commonly right at the end of pregnancy, delivery, or in the first week or two afterwards. So the current diagnosis hypothesis for peripartum cardiomyopathy is that it's a vascular disease, and it's triggered by the hormonal changes of late pregnancy. This is also from Zoltarani, and there are several different things going on here. Prolactin is the nursing hormone released by the pituitary, and one of the models of peripartum cardiomyopathy is that prolactin is cleaved into a pathogenic fragment, the 16 kilodalton fragment, by cathepsin D. And these changes then cause antivascular changes to the myocardium. The other piece here is that the placenta releases soluble FLT1, and that is anti-angiogenic. And when we see all of these different models coming together, we see that there are several different pathways. So some of these have been studied in mouse models. We still need quite a bit more research to fully flesh this out. But what's interesting particularly is that the mechanisms noticed from the basic science side also correlate with what we see from an epidemiologic standpoint of what are the risk factors. So I told you preeclampsia is a big risk factor, and also multi-fetal gestation, like twins. And soluble FLT1 is secreted by the placenta in late gestation, and those levels are higher in both of those situations, preeclampsia and twins. So that kind of correlates exactly with what we're seeing. So here the black line is the relative increase in cardiac output. The red is the relative levels of prolactin and soluble FLT1. And then the blue bars are the incidence of peripartum cardiomyopathy. So you can see that the hemodynamic change of cardiac output does not correlate as closely as the hormonal changes towards the end of pregnancy. And the other really important piece here is genetics, because why would some women present with this and some women not? So the hypothesis is, as a two-hit hypothesis, you must have some sort of genetic predisposition. In a registry of peripartum cardiomyopathy, 15% reported a family history. And that's similar in some additional genetic studies. There are several Titan variants that have been identified and associated with worse outcomes. And it's very interesting. One of the recent papers came out in Circulation from Zoltarani and his group about really showing this overlap. And it's particularly interesting because we tend to, peripartum cardiomyopathy is a diagnosis of exclusion. So if you have a family and with a diagnosis of familial cardiomyopathy, then should they be diagnosed as peripartum cardiomyopathy? And since we're still exploring this area intently, we are right now in the stage of mostly identifying these family histories. And I think that that will be an area that we learn a lot more about in the near future. So I really want to focus on sort of clinical pearls. I could kind of talk about peripartum cardiomyopathy all day, but I think the clinical pearls are something really important and interesting. So heart failure therapy, we want to think about, is the patient pregnant or is the patient breastfeeding? During pregnancy, there are certainly medications that we can use and feel comfortable using during pregnancy. If your patient is volume overloaded, we can use diuretics. And my diuretic of choice is furosemide. It's very effective. The thing to think about with diuretics during pregnancy is that you don't want to volume deplete. You don't want to go overboard during pregnancy because that will decrease the uterine placental perfusion. Beta blockers are used during pregnancy very commonly. High doses have been associated with intrauterine growth restriction, and the fetus can also have some bradycardia or hypoglycemia, which are easily corrected. Some of those studies about beta blockers are blurred because the patients that need beta blocker are often women with cardiac disease. We always avoid atenolol, which has the sort of worst data behind it. But I counsel my patients about beta blockers. The MFMs that I work with are quite comfortable with using beta blockers. They can do fetal growth scans along the way. And so we use that very often. For afterload reduction, we cannot use ACE inhibitors or ARBs during pregnancy. Those are teratogenic, but you can use hydralazine and nitrates. Digoxin is safe during pregnancy. And then we tend to avoid IV nitroprusside due to the risk of cyanide toxicity in the fetus. After delivery, you have many more options. So sometimes there's a bit of a misconception about what medications are safe with breastfeeding. So diuretics we can certainly use as needed. Too much diuretics can make it hard to have enough milk supply with breastfeeding. And then ACE inhibitors, enalapril and captopril, have been approved by the American Academy of Pediatrics that they are compatible with breastfeeding. So I always choose enalapril because it's twice a day instead of 3 times a day. And there have not been any adverse outcomes from that. Beta blockers, again, can continue to be used. Spironolactone, there's some conflicting literature about whether you can use that during breastfeeding, but the literature that I think is most convincing is that it's quite compatible with breastfeeding. Entresto and the SGLT2 inhibitors and ivabradine have not been studied with lactation, so I do avoid those in my patients who are breastfeeding. I think the data will continue to evolve in that area. And so on that realm, I would like to draw your attention to these 2 excellent resources if you are thinking about using medication for someone who is pregnant or breastfeeding. LactMed and the CDC websites here are both very useful to check the data about a medicine during those situations. So now what about bromocriptine, which is a hot topic? It was first really studied in a mouse model and looked very convincing in this model. And so that led to the initial pilot data done in South Africa. And there were 20 patients, so 10 were randomized to receive bromocriptine, and 10 received standard of care. And this is like just the classic study that's really interesting. So the red are the patients that received bromocriptine, and the blue are the standard treatment. So if you look here at the first bar, 40% died. And that is a higher mortality rate than pretty much any other study has reported for peripartum cardiomyopathy. So that is one of the criticisms of this pilot study, is that there is quite a high likelihood of skewed data and kind of some chance in such a small patient population with such a high mortality rate that seems very unusual compared to the other populations that have been studied. also quite a bit of a sicker patient population. And so at least looking at these numbers, bromocriptine looks like an amazing treatment option. There has been there was one additional randomized control trial of placebo versus bromocriptine in 96 women in Africa. I didn't show that slide to you. But this much larger study from the European group looked at a randomized study, but the way that they did the randomization for bromocriptine in their study is they looked at a short duration of bromocriptine versus a long duration of bromocriptine and did not actually have a placebo. Bromocriptine tends to be used quite a bit more in Europe than it does here in North America. So they had not felt that they should randomize against bromocriptine. In this study, they looked at 1 week versus 8 weeks, and the results were not particularly convincing. There was perhaps a trend towards some improvement in patients who received a longer duration of bromocriptine, but really not a huge change. Based on that study, however, the editorial that accompanied that study suggested that we use this acronym called BOARD for anytime we treat peripartum cardiomyopathy that includes bromocriptine for at least a week, as well as standard heart failure medications, as well as anticoagulation, vasodilators, and diuretics, which I think is still controversial. Part of the reason why we have a debate about bromocriptine is the risk that is associated with it. There are associations with thrombotic complications, including stroke, LV thrombus, heart attacks, seizures. It used to be used as a lactation suppressant, but because of these side effects, the FDA no longer approves it for that indication. And then one of the big things is that you cannot breastfeed if you take bromocriptine. Bromocriptine acts to block prolactin, which is the nursing hormone. And so that has implications for many things, especially for women who live in countries where it's hard to access formula or safe water for their infants. So currently the European guidelines give that a 2B recommendation, and the American Heart Association and the Canadian Cardiovascular Society both say that we should not use bromocriptine routinely, and we really do need more data. And this data, we hope, is going to come from Rebirth. This is the North American trial, which is currently getting started. This is being designed by Dennis McNamara at University of Pittsburgh, and this will truly randomize bromocriptine versus placebo. Several centers are enrolling, and we will also be having an observational cohort for women who wish to breastfeed and would not want to be randomized to receive bromocriptine, and so they will be followed as well. And so that leads to the question about breastfeeding. Some women actually come to my clinic sort of down the road for a second opinion, and they do tell me that they've had doctors say, no, you absolutely must stop breastfeeding. But let's look a little bit closer at that. There are some expert opinions that maybe we should not be recommending breastfeeding because of the idea that the more prolactin will be perpetuating this disease process. There's also a pretty legitimate concern if you're in the intensive care unit or intubated, the metabolic demands of breastfeeding are likely too much, but that would be very few situations. And then some doctors tell patients, well, you can't breastfeed because we have to give you cardiac medication. But as I showed you on the prior slide, there are many heart failure medications that we can use. So that shouldn't necessarily preclude breastfeeding. And then on the flip side, there's actually never been a study that shows any adverse outcomes associated with breastfeeding. There's clearly a survival advantage to infants who are in developing countries. And we know that there are several maternal cardiovascular benefits to the mom, less diabetes, less cardiovascular disease, some very interesting studies about that. This is the best piece of data that I've seen about breastfeeding. This is from the IPAC study, also from University of Pittsburgh, but multi-center enrollment. And the blue are patients who did not breastfeed, and the green are patients who did breastfeed. And so if you look at the 6 months, 12-month outcomes, there's no significant difference in the left ventricular ejection fraction. So by 12 months, there's no significant difference between those two groups. At 6 months, it looks like there might even be a trend for the breastfeeding group to have had a slightly higher ejection fraction than the non-breastfeeding group. So I think there's clearly more studies that can be done in this field, but at least based on this, most expert opinion states that clinically stable women should not be discouraged from breastfeeding their infants. Women come from all different types of attitudes and feelings about this. And so for some women, that's a very important piece of their choices. So then what about anticoagulation? Because bromocriptine is associated with prothrombotic complications, at least prophylactic anticoagulation is indicated in the setting of bromocriptine. But bromocriptine aside, there's also suggestion that women with peripartum cardiomyopathy are at quite a bit higher risk of thrombus, embolism, and therefore there's some expert opinion about using therapeutic anticoagulation. Part of this is the very high hypercoagulable state of pregnancy and postpartum. And the risk there increases in the third trimester, and it's highest in the postpartum period, especially in the first week after delivery. Additional risk factors for thromboembolism that might be important are patients who've had cesarean deliveries, as well as a history of clotting or obesity, hypertension, twins, preeclampsia. So those are all things that may increase the risk in your patient. I like this graph that shows the odds ratio for thrombotic event postpartum. So along the x-axis is the time after labor and delivery. And you can see in that first 3 weeks after delivery, the risk is really super high, and then it diminishes quite a bit. So, anywhere from like 8 weeks postpartum, and a lot of us will use 12 weeks postpartum as that highest risk of thrombotic event. So in terms of peripartum cardiomyopathy, this is data from 739 women in the international registry run by Karen Sliwa and colleagues. And they looked at outcomes at 6 months and reported a thromboembolic rate of 7%. So that's pretty high, and that correlates with data from the US, from the national inpatient sample that also reported a similar rate of thromboembolism. There's also several small case reports looking at the incidence of LV thrombus in peripartum cardiomyopathy, and that clearly can be associated with very adverse outcomes. The current recommendations, this is from the European guidelines, is that clearly if you identify an LV thrombus, you should definitely be anticoagulated. So that's pretty clear. But the piece that I would think about too is like when you do your echo, to make sure that you're looking at the apex and really like paying attention, trying to look for any evidence of an LV thrombus. And then if your patient has heart failure and also has atrial fibrillation, particularly in this hypercoagulable state, that anticoagulation can be very important. The AHA guidelines give this a moderate level of consensus about anticoagulation and say that it's reasonable in patients with peripartum cardiomyopathy with severe LV dysfunction to prevent thrombus, particularly because of this hypercoagulable state. So if you need to anticoagulate your patient, what can you use? So warfarin is safe to be used with breastfeeding, and that is pretty clear data. Warfarin is not detected in breast milk, and infants have normal anticoagulation. And there's a case report that I think is really very interesting of a patient, a mom who accidentally started taking very high doses of warfarin, 25 milligrams daily for a week, and her INR was higher than 10. And then they checked her 8-week-old breastfeeding infant, and the infant's INR was normal. So I think that's a very nice illustrative case. Heparin is also safe with breastfeeding. It's a large molecule that doesn't really get into the breast milk. And then what about the novel anticoagulants? I think this might evolve more in the future. There's a few case reports so far that rivaroxaban is shown in very low levels in breast milk. So that may be an option. This shows the concentration of rivaroxaban in breast milk. And dabigatran also is detected in such tiny concentrations that it's very likely that that would also be safe. Not currently in the guidelines, but I do think that it may be promising. So let's talk a little bit about outcomes. Sudden cardiac death would be the most frightening complication. And how can we lower the risk for women who have recently delivered and have peripartum cardiomyopathy? So unfortunately, a lot of mortality happens within the first 6 months after diagnosis. And so this shows the number of days since the time of delivery, and the incidence of sudden cardiac death is quite high. A lot of these complications here. Of the patients who die, 25% are generally associated with ventricular arrhythmias. But over that first 6 months is also the same time when significant recovery occurs. And so we don't necessarily want to jump into giving someone an ICD prematurely if they will recover. The risk of sudden cardiac death has been studied. This is from the nationwide inpatient sample, and 2% of patients had cardiac arrest. There was also ventricular tachycardia and ventricular fibrillation that was identified. And so the question is about LifeVest and wearable cardioverter defibrillators. This study was from the company that does the LifeVest, and they looked at 107 women in their database with a diagnosis of peripartum cardiomyopathy. And a lot of women had trouble wearing this because it's very uncomfortable, especially if you're breastfeeding and you're postpartum. In this cohort of 107, none of the women had any shocks, and the average follow-up was 4 months. In contrast to a study out of Germany that looked at 49 women with peripartum cardiomyopathy with a very high rate of cardiac rhythms that are clearly necessary to have a defibrillator. So 5 episodes of ventricular fibrillation that were appropriately shocked, 2 episodes of sustained VT. So these data are a little bit in conflict about what is the risk of a fatal arrhythmia, but nevertheless, it's quite concerning. In the ROPAC data, again, or the it's from the International Peripartum Cardiomyopathy Registry. Women who died within the first 6 months, 30% were sudden death. And so the authors recommended that we consider the LifeVest to prevent sudden death. The other topic that's pretty interesting to think about would be the use of a subcutaneous defibrillator. And very few women do receive ICD at hospital discharge, which is probably appropriate because we want to allow time for recovery. The overall prognosis for peripartum cardiomyopathy is pretty much all over the map. A lot of studies of peripartum cardiomyopathy look at outcomes up to 6 months or 12 months. But if you think you have you can imagine having a young family, you really want to know what the long-term mortality and outcomes are. So here I plotted a variety of different studies and how long the patients had follow-up. And the mortality rates are quite variable. There's a lot of geographic variation in mortality rates, but we certainly need more data to figure out who will do well over the long term and who needs more aggressive intervention. These are some of the big studies of peripartum cardiomyopathy. The percentage of recovery is variable, 72% here in Germany, 23% in Nigeria, 72% in the United States, and 46% in the European registry. And mortality kind of matches along with that, higher mortality with lower rates of recovery. And you can see here there's a variety of different lengths of duration of follow-up. So a subsequent pregnancy is something that many women with peripartum cardiomyopathy desire. In some studies, up to 3/4 of patients may be wanting another pregnancy. It's a common reason for consultation in my clinic is preconception counseling for another pregnancy. So this is something that comes up very often, and it's a very difficult conversation to counsel a patient about the risk of heart failure with another pregnancy. When we think about the risk of another pregnancy, it really depends on what their LV function is before that pregnancy. And if someone has recovered completely, the risk is quite a bit lower. So that's why this is in green on this slide. Many studies have used an ejection fraction of 50% as that cutoff to define recovery, which of course we could argue, is that really normal or not? And more studies are needed to figure out how can we predict which patients will relapse during another pregnancy and which women won't. But in general, if we just look at the left ventricular ejection fraction and we put together data from several different sources, then we can quote a 31% risk of symptomatic heart failure with another pregnancy. And then beyond that, the really important piece to counsel patients about is that if your heart function decreases again, it might not recover a second time. So even if you recovered after your first pregnancy with peripartum cardiomyopathy, you won't necessarily recover completely with another pregnancy. That being said, the risk of mortality in multiple studies is basically zero if you have had full recovery. And I think a lot of that depends too on what's your patient care team, who's following you, and how closely are you watching for any complications that you can then treat early. There's also risk of premature delivery, which is important for counseling. On the flip side, patients who have not recovered their LV function are at notable risk during another pregnancy. The risk of heart failure relapse, 50%. The LV dysfunction will likely persist. About 50% of women will deliver prematurely, and most alarming is close to a 20% risk of maternal mortality. And again, you can argue, someone whose ejection fraction is 49% is probably going to have a better outcome than someone whose ejection fraction is 20%. But just from a global standpoint, these are the percentages that we often refer to. Then how should we manage a patient during another pregnancy? Before conception, we would like to do a full evaluation. if possible. That doesn't always happen because not everyone is planning their pregnancies and are sometimes surprised. And then during pregnancy, we tend to do an echo and a BNP each trimester, and then try to aim for that last assessment to be in the last month of pregnancy. We also like to do echo and BNP in the hospital before the patient is discharged and a month after delivery. And especially remember that month after delivery is that highest risk time for heart failure. We sometimes think about once we've gotten the patient through delivery, like great, but it's actually all that fluid that gets resorbed after delivery is a very high risk time for fluid overload after delivery. So those patients need to be followed quite closely. So in order to prevent any surprises, I want to just touch on contraception, which we don't get trained on during our cardiology fellowships, but particularly in this patient population is really important for us to know something about. Sometimes patients are told, well, you have a heart issue, so you can't use any estrogen-containing birth control. And that may be true in that first 6 weeks after delivery when you're very hypercoagulable, but the recommendations are not clear that we need to continue to avoid estrogen. And the most important thing is that if you have a high-risk patient who you would really worry about during pregnancy, it really would be better to be on birth control that is reliable and effective than to have a surprise pregnancy, which would be really quite a bit more risky. So things to consider is the IUD, very effective, long-term, lasting. The copper Paragard is fine, but that can sometimes cause higher increased menses, more bleeding during the periods. The Mirena has progesterone analog and it's very safe, very effective. So there's no reason to suggest that you have to use a copper IUD. Progestin subdermal implant would be fine as well. And then Depo shots, progesterone only pill, that's the mini pill. The problem with the mini progesterone only pill is that patients have to take it exactly on time and not miss any doses. So for some of my young women who are juggling a lot of things and have trouble taking all their medications, it's a really poor choice for birth control, actually. Condoms, there's been a reported 20% failure rate. So I like to remind patients about that when they're choosing their birth control. So sometimes patients are told you can't be on birth control because of your heart, which I would disagree with. And I would encourage you to talk about contraception with all of your young patients. And mental health is so important. If you can imagine what these patients are going through. In studies that have looked at mental health, they found more than half of women report depression or anxiety or a problem with their quality of life. 32% diagnosed with depression, 3% prior to the diagnosis. And keeping patients involved, counseling them can, I think, help with some of this. And so as I kind of sum up here, the importance of a multidisciplinary program and experts from many different areas to manage these patients is really important. And teamwork is always the way to go. So when we circle back to the learning objectives and the take-home points, we talked about the definition that it's the left ventricular ejection fraction less than 45%. It's the diagnosis of exclusion. So we think about those other items on the differential diagnosis, and the BNP level can be really helpful. Medications can be used during pregnancy, especially diuretics and beta blockers. Isodil and hydralazine can be used if you need afterload reduction. And with breastfeeding, remember that it's fine to use enalapril, spironolactone, beta blockers, and diuretics. And then think about anticoagulation for your patient if they have a very low ejection fraction, if they have risk factors, pay attention for any possible LV thrombus. especially if they have had a cesarean or other risk factors. Bromocriptine, stay tuned for the rebirth study. And you can think about the wearable cardioverter defibrillator life vest early on as well. And then for a subsequent pregnancy, it really depends on the recovery status of the left ventricular ejection fraction, requires a lot of in-depth conversation, and remember to talk about birth control and mental health. So with that, I thank you very much. I really appreciate being able to talk with you today, and I would welcome questions, and thank you again.
Thank you so much for an excellent talk, Dr. Davis. I'm not sure if Dr. Hunley has any comments. If not, I definitely have some questions for you. All right, well, we'll get started. So, there is a question in the chat. I'll start off with that. So Sarah Pachuli asked, can you comment on pregnancy and the risk of SCAD?
Sure, not related to peripartum cardiomyopathy, but SCAD can be associated with pregnancy. There's some data that suggests maybe we're like overestimating the association with pregnancy, but in any woman who's postpartum or pregnant, who's coming in with chest pain, thinking about SCAD is incredibly important, that you would not want to miss that diagnosis. Yeah, I could sort of give a different talk about SCAD itself. I would love to come back and do that. It's a very interesting topic. We want to be careful to, we can often medically manage those patients instead of the risk of a lot of intervention can perpetuate those dissections. So we want to be careful when we take patients to the cath lab and do that in a gentle fashion would be one of the important teaching points. So SCAD should also be on your differential.
Great, thank you. Dr. Crone asks, if you have a patient with a history of peripartum cardiomyopathy with normalized EF, do you use beta blockers through another pregnancy or wait to see if the issue develops?
That's a great question. And when we were putting together our JACC paper, we were debating that quite a bit, like how strongly should we recommend beta blockers during the second pregnancy or subsequent pregnancy? My practice is generally, if someone is on beta blockers and has been continuing on beta blockers, I generally continue them. If someone has had a recovered EF and they're not on beta blockers, then I don't generally start that during the next pregnancy. Whether that's the right thing to do, I'm not sure. We need more data, more studies. Anyone who wants to collaborate with me, let me know, because this is something that we really do want to collect more data about. It makes me think too about when I'm counseling patients for a subsequent pregnancy, I do make sure that I've taken them off their ACE or ARB or any medications that cannot be used during pregnancy. Then I generally wait about 3 months and recheck the ejection fraction to make sure that it is stable and continues to be normal before another pregnancy.
Great. Dr. Abate said, excellent presentation, thanks. I may have missed this, but there seems to be an overlap between hypertensive heart disease and postpartum cardiomyopathy, especially in Black or African-American women. Any recommendations suggestions regarding this?
There's definitely an overlap between hypertensive disorders, hypertension, preeclampsia, and peripartum cardiomyopathy. And that is very true. Both of those are more common in Black African-American women. And I think there is a lot more emphasis that's needed about diagnosing hypertension and diagnosing risk factors, improving prenatal care, and making sure that we're treating that. There's no, there hasn't been a study that shows treating hypertension or any particular other risk factor during pregnancy would necessarily lower your risk of peripartum cardiomyopathy. But prenatal care is important. Some patients who have risk factors for preeclampsia, taking a baby aspirin has been shown to lower your risk. And so making sure patients are being treated properly and getting good care is certainly important.
Excellent. There's another question. Is there a preferred beta blocker during pregnancy, such as labetalol?
Oh, that's a super question. Thanks for asking that. Labetalol is used quite a bit by my maternal fetal medicine colleagues, particularly treating hypertension, which we wouldn't use in our general cardiology non-pregnancy clinic. Labetalol is fine if a patient needs to be on that. If I'm treating a patient for cardiomyopathy during pregnancy, I tend to use metoprolol tartrate, even though if they were not pregnant, I would use succinate, or I would use carvedilol or bisoprolol. And that's generally because we just have the most experience using metoprolol tartrate during pregnancy. That being said, I think metoprolol succinate is also fine. Carvedilol has been used during pregnancy as well. So I'm also comfortable with those, but my typical go-to would be metoprolol tartrate, but not atenolol.
All right, excellent. The next question is, can you comment on cardiac rehab and exercise in patients with peripartum cardiomyopathy?
Oh, that's another good question. Some of my patients really need that. And my dream would be to have a study that looks specifically at cardiac rehab for this patient population. Actually, my dream, I'll tell you, is to have women come with their babies and to offer childcare for them so that they can come and have a support group and exercise, with other women. Because part of the really difficult thing about this diagnosis is that women feel so isolated. They're so young. They have so many responsibilities, and to be diagnosed with heart failure is so overwhelming. A couple of times I sometimes do refer my patients to cardiac rehab. And some of my patients feel so uncomfortable with the other people that are at cardiac rehab, which are a completely different patient demographic, that sometimes they get commented like, "Oh, you're so young. Why are you here at cardiac rehab?" And that can kind of make them feel more isolated. So there's a whole psychological piece to that. I do think rehab and exercise is super important. And we do need a good way to encourage it. But there's not a study that's shown the physiologic benefit, but intuitively it certainly makes sense.
All right. Dr. Saloom asked, thank you for the great talk. Has anyone looked at relaxin levels during pregnancy in peripartum cardiomyopathy patients to determine if lower than normal levels contribute to cardiac complications?
Yes, I cut that slide out so I wouldn't go over time. Relaxin has been looked at. And I would be really curious if you have some experience with relaxin, or what kind of brought that to your mind. I would be happy to talk more about that. There's a lot of interesting studies that could be done in this patient population.
Excellent. I have a few more questions for you, Dr. Davis. So in patients who have had peripartum cardiomyopathy, are there any factors that you look at that may be associated with the likelihood of recovery, maybe echo findings or history? And is there a time frame that you look at that probably within the next 6 months, EF may have recovered, or a year or anything like that? I'm asking to predict here, but...
Yeah. So two things there. So in terms of prognostic factors, some of the things that we look at is, yes, if you recover very quickly, that's a good prognostic sign. If your initial ejection fraction at the time of diagnosis was not that depressed, that tends to have a better outcome. So the lower your ejection fraction, the more worried we are about your long-term prognosis. And then LV dilation has also been looked at. And those are some of the big ones. Sometimes BNP is also associated with that. But it's really interesting, there's not a great primary marker to know if someone will recover or not. The other item is genetics. So sometimes, particularly in my patients who haven't recovered, genetic testing can be really useful. And we will be getting more data about whether that is associated with lack of recovery. But even though we usually see recovery within that first 6 months, patients can take 2 years to recover. So I think being aggressive with our cardiac medications and continuing to follow those patients is really important.
Excellent. And for patients who have peripartum cardiomyopathy and may end up in cardiogenic shock prior to delivery and are in the ICU, at what point do you, and of course this is in collaboration with our OB colleagues, at what point do you think that, okay, we need to get this baby delivered, or what else can we do to help support the mom and the baby during that time?
Yeah, fortunately, that doesn't happen very often, but when it does, it's quite frightening. And we're lucky here to have such a good multidisciplinary group to think through these concerns. Someone who that would be one indication for a premature delivery is if someone can't be stabilized, or even a cesarean if they're having a heart failure that we can't. That's like very severe. But the flip side is that you don't really want to deliver someone who's unstable. So stabilizing someone would be very important. Diuretics, kind of your standard cardiac medications in the ICU. Sometimes we deliver patients in the ICU and have additional backup as needed. You can have ECMO on backup. So it does become a very kind of complicated decision-making process.
All right, we're 1 minute past 8:30. Thank you so much, Dr. Davis. Thanks again for coming. And please, for everybody else, do not forget to text the CME code that's on the current screen. Thank you very much.
Oh, thank you very much. I appreciate all the questions and interest and the opportunity to talk to you today.
It's very nice meeting you, Dr. Davis.